Hi, welcome to my presentation on medical cannabis for osteoarthritis. Let's begin. So, quick overview on what osteoarthritis is. It's inflammation of the bone and joints. It's a degenerative bone disease, which most often affects the joints of the hands, the knees, the hips, the neck, and the low back. It's also the most common form of arthritis, mostly affecting older people over 50, especially women after menopause. This can also affect younger people after the joint injury or those with genetic defects in the joint cartilage. People with OA often complain about stiffness, reduced range of motion, or pain when using the joint. There's also maybe swelling around the area. It can get deformed, like the joint can get deformed, and then they might feel instability in the joint. The degeneration not only causes damage to the bone, but also the soft tissues surrounding the joint, such as the tendons, ligaments, synovium, cartilage, and meniscus. Over time, the joint may lose its shape and lead to the formation of osteophytes or bone spurs, which lead to varying levels of pain depending on the amount of degeneration and where the arthritis is. Depending on symptoms, a person may be prescribed NSAIDs, analgesics, corticosteroids, injections, or opioids. So what role does the endocannabinoid system play in bone health? Our endocannabinoid system is made up of receptors found in almost every tissue of the body. CB1 receptors are mainly found in the brain and the CNS. CB2 receptors are along with other receptors such as GPR and TRP receptors, are found in the periphery of the body. The main cannabinoid receptors involved with bone homeostasis are the ones found in the periphery, so specifically the CB2, the GPR55, and TRPV1 receptors. The main endocannabinoids that activate these receptors and contribute to bone growth and reabsorption are 2-AG and anandamide. But there's also new research pointing to the role of oleic acid amide, which contribute to this receptor's activation. Recent research findings have found that our endocannabinoid system plays an essential role in the formation, the density, and the maintenance of bone health, and it has a direct effect on osteoblast and osteoclast apoptosis and progeneration. The endocannabinoid system is activated in response to pathologies related to osteoarthritis, rheumatoid arthritis, and osteoporosis. And also, it's an essential element for proper bone growth in utero and throughout our life cycles. Most studies on this are preclinical. So in vivo studies show that CB2 receptor agonists may also act indirectly to decrease bone reabsorption via anti-inflammatory effects, including decreased expression of cytokines, which promotes bone reabsorption, TNF, and interleukin-1, and increased expression of interleukin-1 receptor antagonist, which is present in bone and suppresses osteoclast formation. So decreases inflammation, pretty much. CB2 agonists also decrease oleoserine, which is a CB2 mimetic that regulates bone turnover. GPR55 is involved in osteoreabsorption and antagonism. With CBD in vitro, it showed increased in osteoclasts. Or antagonism, of GPR55 showed that CBD increased osteoclast by antagonizing GPR55. TRPV1 is expressed in osteoblast and osteoclast cells. It's been shown to play a role in the cell synthesis and degradation. In vitro anandamide activation of the TRPV1 channels increased bone turnover and CB2 expression of osteoclast by like 10 times the amount. So, how do cannabinoids affect the bone? So anandamide is a major component of the skeletal endocannabinoid system. In vitro, anandamide activation of the TRPV1 channels, like we just said, increased bone turnover and CB2 expression. MAGL is an enzyme that breaks down 2-AG, and inhibition of MAGL will increase 2-AG concentrations in the body. In vivo, the inhibition led to a decrease in bone volume due to cannabinoid receptor-mediated osteoclast activity, which insinuates that increasing 2-AG also increases osteoclast activity. Purified isolated CBD does not act the same as a whole plant preparation, including CBD. So purified isolated CBD does not directly bind to CB1 receptors. It has an affinity for CB2 binding, leads to an antagonistic response to CB2 receptors, which generates osteoclasts. But in a study examining whole plant extracts of CBD, the market products actually showed a partial agonist binding to CB2 receptors, which would, in theory, promote osteoblast generation, strengthening the bones. This suggests that CBD's function on bone homeostasis depends on accompanying cannabinoids and constituents. CBD also has an antagonistic effect on GPR55, increasing osteoclasts in vivo. CBD was associated with a decreased inflammation and inflammatory markers in experimental arthritis models as well. It also enhanced fracture healing in rats. CBD, lastly, is an inhibitor of FAH and MAGL, which leads to increases of anandamide and 2-AG in the body. THC is an agonist to CB1 and CB2 receptors, but its function differs from CBD. And in vivo studies, THC was shown to impair the femoral and vertebral growth in gravid mice and also decreases epiphyseal growth in vitro. However, when used in combination with other phytocannabinoids in vitro, CB2 mediation led to increases in fibroblast colony-forming units, increases in alkaline phosphatase expression, collagen synthesis, and so on its own, deteriorates bone, inhibits function in preclinical trials, but when used in combination in low doses, actually increases bone structure. So not much research has been done on other minor cannabinoids and their effects on the skeletal system, but what we do know is that CBC is a selective cannabinoid receptor 2 agonist, which may lead to inflammation modulation. THCV might also be an indirect agonist to CB receptors. And then there's some other minor ones like THCP, which has a strong binding affinity for CB1 and CB2, stronger than THC, actually. But this gets further complicated as all the phytocannabinoids tested, which behave as agonists, switch to inverse agonists in the presence of selective receptor agonists. So what this means is that the presence of CBC, which is a selective receptor agonist, has the ability to change the function of the other cannabinoids, the function that they have on osteocytes. Okay, so most of this research is preclinical. There's not enough human trials to recommend a standard administration of cannabinoids for the treatment and symptom management of osteoarthritis. That being said, there is no harm, for the most part, in trying cannabinoids for the management of pain and inflammation. Research looks promising. So what we know for sure is that the endocannabinoid system is a major player in maintaining bone and joint health, and that the phytocannabinoids, without a doubt, target the receptors that maintain bone homeostasis. Preclinical data also points in favor of using the whole plant preparations with isolated cannabinoids showing genesis of osteoclasts, which break down the bone, and the whole plant preparations leading to increased bone strength and density. The cannabinoids have also been shown to activate the TRPV1 receptors, like we mentioned, which are important in modulating pain and osteoblast homeostasis. They also modulate inflammation and inhibit leukemia inhibitory factor, which is LIF, which is a cytokine that contributes to the pathogenesis of both OA, osteoarthritis, and RA, rheumatoid arthritis. In the maintenance of bone health, CB2 receptors are showing to be the main target for treatment within the ECS, or the endocannabinoid system. CBD and CBC are the two main cannabinoids that have therapeutic potential And there's also potential to use terpenes, especially beta-caryophyllene, which is shown to produce significant elevation in collagen content, alkaline phosphatase activity, osteocalcin production, and mineralization in vitro. Early stages of OA in the disease progression, osteoclast and osteoblast activity increases by 190 and 96%, which rapidly remodels the bone and leads to bone loss, deformation, and pain. Because cannabinoids have the potential to modulate osteocyte apoptosis and genesis, it's not a wacky hypothesis to think that phytocannabinoids are a potential effective treatment, not just for the maintenance of pain, but for the prevention and even possibly the reversal of the disease. The whole plant cannabinoid preparations, the use of whole plant cannabinoid preparations, which are low in THC, are generally well tolerated. The only thing that could be a potential caution or contraindication is the use of cannabis with certain medications, such as benzodiazepines, opioids, or heart medications. Since opioids are a common treatment for moderate to severe pain from OA, a patient who wishes to use cannabis preparations internally needs to be monitored, and as the patient titrates up with the cannabis. They will also need to be monitored as they slowly decrease their opioid use. This could take, anywhere from 3 weeks to a couple months. Typically, a low and slow titration is recommended for patients starting with CBD and then slowly adding in THC over time. This is something I would recommend a patient to do once they have reached a point of adequate system relief. They can begin to slowly decrease opioid medications. So, the cannabinoid spotlight, CBD, CBC, CBG, and beta-caryophyllene, which is not a cannabinoid, but a terpene that affects the system, are very important, in my opinion, since they all specifically target the bone, decrease pain and inflammation. THC does not target the bone, but it does provide analgesic effects, so it can be added at low doses if the pain relief is not enough solely with these CBD, CBC, CBG, and phytocannabinoids. CBN is not one that I mentioned here, but it's also anti-inflammatory and analgesic, but it has the potential to make someone sleepy. It does not target the bone specifically, so it's not an essential cannabinoid for OA, but it's something that could be added in. It's not going to harm anything. So do we do topical? Do we do internal? Do we smoke it? What do we do? Topical applications have the benefit of working in isolated areas, which is great if you're taking medications that you don't want to combine cannabinoids with. But with the internal ingestion of cannabinoids is going to affect the body systemically. An in vivo study showed that topical CBD gel reduced pain and inflammation. And another showed that oral and injectable combination of CBD prevented joint damage associated with arthritis. So, just from all the preclinical data, I would suggest that a combination of both topical and oral might be the best route of administration, just because you're working on a cellular level and topical applications might not go deep enough or affect the osteocyte homeostasis as well as if you were to take it on an internal level. So getting the right combination of cannabinoids in the preparation, like we discussed, is very important. And so is the topical carrier, in my opinion. This is my personal opinion. If I was to make my own topical, I would suggest a carrier of castor oil since it goes deep into the joint instead of using the topical kind of like a lotion. You don't want something that's going to absorb really quickly, or you want it to be able to sit there on the joint for a long time, slowly getting into the joint area. So I would use it more like a plaster that sits on the area for an extended period of time. Vaping or smoking is also an option for breakthrough pain with the CBD chemobar, since pain relief is usually rapid. However, dosing is more difficult with this method, and pain relief doesn't last as long. A safe protocol for internal self-titration is to start with 5 milligrams of CBD-rich oil or tincture 2 times a day. You can slowly increase that by 5 to 10 milligrams every 3 days until you reach adequate relief or 40 milligrams per day. If the relief is sufficient, you can stop raising the dose and stay where you're at. If it's not, and you've reached 40 milligrams of CBD, you could slowly add in 1 to 2 milligrams of THC and increase by 1 milligram every 3 to 4 days until adequate pain relief is achieved. So, reference page ready. Let's just wrap it up. There's a great need for more research and human trials, not only to prove the efficacy, but to test which cannabinoids and applications prove the most successful for treatment of OA and other pain conditions. The preclinical data is promising. It shows that cannabis has a lot of potential for the treatment of OA. However, the data does not support a standardized recommendation for healthcare practitioners to promote the use of cannabis for this condition. However, the risk is pretty low, and there's nothing wrong with you trying it out under the guidance of your cannabis-informed healthcare practitioner with quality products. All right, thanks for your time.